the October 3rd edition. Can't believe it's October already. Today we have Dr. Daniel Niven from the Department of Critical Care. Dr. Niven is an associate professor at the University of Calgary and head of the Peter Lougheed Critical Care Group, runs the ICU over there. But his area of research interest is in blood transfusion and blood preservation in critical care patients. Today, he is going to speak to us about reducing avoidable blood tests and blood transfusions in patients admitted to high-risk surgical units, which will include our cardiac CCU patients. Okay, thank you, Dr. Niven. We look forward to your talk.
Thanks a lot. Thanks for having me. And yeah, as Dr. Howard said, I'm one of the intensivists in the zone. And I wear a research hat. I did training in knowledge translation and health services research. And so my research focuses on resource appropriateness, and blood transfusions happen to be some low-lying fruit that was able to get funding. And hence I've now dug myself into the transfusion medicine literature and become more knowledgeable in that sphere. So that's what I'll speak to you about today. Just going to advance the slide, show you the mouse. There we go. So by way of disclosures, I'm not a transfusion medicine specialist, just to put that out there. That was not my training. I'm an adult intensivist with health services research interest, and I'm leading a team who has a passion for healthcare resource appropriateness. So that's what I bring to you here today. And I've had some funding that's helped support my research, but no other significant conflicts of interest. By way of objectives, I have four. First would be to review the importance of blood component appropriateness and introduce our project. Second would be to review the guidelines we've developed and the clinical decision support tools that are coupled with those. Third would be to review data on blood component utilization within your CCUs. And then finally, to review how we can integrate this into your practice, hopefully convincing you of the seamless integration that we are aiming to achieve. We have a number of partnerships. Some of them have provided funding. Some of them have provided personnel and infrastructure. They're all very important in helping to achieve success, and they're all listed there. I like to ground this type of presentation in, what defines low value care. That's really kind of what we're after here, is trying to, reduce the low value care within the system. So by way of a definition that derives from a paper published years ago by kind of one of the pioneers in this, Adam Elshog, a scientist from Australia, they sought to define this as an intervention in which evidence suggests it confers no or very little benefit for patients, or the risk of harm exceeds probable benefit, or more broadly, the added costs of the intervention do not provide proportional added benefits. So I like to start with that because, I think it's resonant, it makes sense, and it's really why we should seek to reduce low value care where possible. Reducing low value is important for three reasons. First and foremost is to our patients. Why ought a patient be subject to the risk of an intervention if there's no discernible benefit? It just doesn't make sense. To the health system, through both reducing waste within the system, as well as reducing costs. And then finally, to the broader society through actually reducing biomedical waste and reducing healthcare's environmental footprint. I don't know if you've noticed, but healthcare is a pretty plastic-rich environment. So, wherever there's an opportunity to reduce the expulsion of that plastic, it would be really important. This is just to highlight that, this project derives from past work. So, previously we had received funding from CIHR to reduce the use of low-value albumin or unnecessary albumin for fluid resuscitation in the ICUs. We did not do this in CCUs, though I suppose we could have. It was first focused in the ICUs in Alberta. It was a population-based step wedge quality improvement intervention trial. And as you can see on this slide, just looking at the graph, over time, we achieved a fairly significant change in the amount of low-value albumin use within the ICUs. You don't need statistics to tell you that. You can see there was a decrease over time and multiple, bumps along the way, but otherwise a reduction over time. So through that project, we managed to help nearly 3,000 patients avoid unnecessary blood product exposure, a 36% relative reduction in low-value albumin use. We saved more than a metric ton in biomedical waste. And, now, if you were to actually take this out past April 2022, which is when the slide was created, we're upwards of $1 million in real savings. So, past success is what, we built this blood product appropriateness project on. So moving on to now why I'm here, which is introduce you the project, which we are looking to bring to the CCUs in the Calgary zone and in fact throughout Alberta. Don't misuse my blood, as was named when we applied for the Prius 5 grant. And that's right, I said Prius 5. So this is a Prius 5 funded project. And the reason that we're moving it forward now is that COVID derailed this significantly. We actually got funding right at the time COVID hit. And so you can imagine this just wasn't going to move forward at that time. So thanks to Alberta Innovates, who was understanding of that, has extended our funding out to September 2025 in order to get the work done. So the goal is lofty. We're seeking to reduce avoidable blood transfusions and avoidable blood tests among patients admitted to critical care and high-risk surgical units. Definitions are up there. So the blood components would be the common ones. You know, red cells are our heavy hitter. They're the ones I think we can make the biggest difference in. Platelets, plasma, fibrinogen, and PCC are also important and are really coupled with any discussion on blood components. The blood tests are common ones. There's nothing fancy there. You know, our heavy hitter there is probably blood gases, particularly within the ICUs, as they're both common and costly. But then otherwise, you know, we have the other CBC, electrolytes, creatinine, et cetera. You could imagine the list. The units are quite a big number. So this is where, you know, we're now seeking to manage the breadth of this. When we put this application in, it just seemed to make sense to include all these units, and now managing it, you know, has suggested why we had to at least truncate it at those numbers of units. So it includes all 34 of Alberta's, you know, ICUs, CVICUs, CCUs, and pediatric ICUs. So there's 34 units there all told, plus a few high-risk surgical units, cardiac, vascular, and trauma surgery in Calgary and Edmonton. Really important, we're not seeking to get into the operating rooms with this. This had to be, you know, we had to call the scope at some point. We could have easily done that. There's certainly lots of blood products used in the operating rooms, but that's not the goal. So the goal really is the post-operative care of those cardiac, vascular, and trauma surgery units on their wards, not within the OR. We're also not seeking to get into the emergency department, though you could potentially extrapolate some of this work there. That's not the goal. So all told, 40 units that we're seeking to implement within, both within two arms of a project that contain both a blood transfusion and a blood test arm that, for reasons I'll describe, had to be decoupled from one another. So today we're talking about the blood transfusions work. The blood tests work was just not as ready for prime time and needed more research to be done to define, you know, what is an avoidable blood test. Although you can probably conceptualize in your mind what might be avoidable, putting that down into a, you know, more black and white definition on paper is a lot more complicated. So why is this work important? Well, Alberta data, which we have great data, we actually have the luxury of great data in Alberta, demonstrates that up to 60%, and I have a further refined estimate of that, but up to 60% of blood transfusions in these broad critical care units are incongruent with contemporary guidelines. So it's a pretty big number. And blood transfusions are costly. You know, they're not cheap, anywhere between $400 to $700, depending on what you're looking at. Red cells being the higher end estimate, and, you know, things like plasma and platelets probably being on the lower end estimate. And they're also associated with risk, right? We've all seen transfusion reactions. They're not common, thank goodness, but they do happen. So if they're avoidable, why shouldn't we seek to do that? And in fact, you know, rather surprising, but really not so when you actually think about it, when we were putting the grant together, critically ill and high-risk surgical patients, that population consumes between 20 and 40% of all blood products in AHS. So around a $20 million cost per year. And of course, there's a lot of that that's necessary and appropriate. And, you know, we would not seek to change that. But there is, as you can see there with that 60% number, a proportion that is definitely modifiable. So coming back to why we do this and why we're seeking to reduce low value care, you know, in the three main spheres. So from a patient's perspective, this was a quote we received from an anonymous donor at the time we submitted the grant. And so I'll just read it. As a potential recipient, I would only want to receive blood if there were no other options, because there are risks to receiving blood, and I would want to ensure that the blood is there for those that really need it. So that's, you know, when we think about our patients, that's what they think. From a health system perspective, this is data we received from our transfusion medicine colleagues on blood products that are wasted. You know, they're thrown out, which we also want to avoid. And in the interest of time, you know, I won't go through all the numbers, but just focus on the red font, which is suggested that 30% of the waste that's thrown out was associated with potentially unnecessary order. So pretty big number within their waste. And then from a costing perspective, you know, we had gotten detailed costing data at the time the grant was submitted. And so, you know, the project both has a blood test and a blood component transfusions arm. Within the blood component transfusions arm, if you just focus on the bottom, you know, you could see there that the spending on that per year is around $20 million. If we just affect a 30% relative decrease in that, that alone can potentially liberate up to $6 million in health system capacity. Some of that through real cash savings. So there's definitely an opportunity. From a societal perspective, this is just this year where there's a national shortage in blood products, particularly red blood cells, particularly a subtype of red blood cells. And in fact, there was a green phase advisory, you know, submitted from Alberta Precision Laboratories within Alberta, where we did have supply, but contributing to the national supply, suggestive of the fact that we do have a shortage and we need to be more cautious with our blood product usage. And that's just this year. So you're probably sitting there thinking, like, what is he talking about? This practice is based on a trial that I know from 1999, a Canadian trial from the Canadian Critical Care Trials Group, published in the New England, called TRIC, which really informed a number of other trials after that, examining a restrictive versus liberal transfusion approach. And you're right, it was published in 1999. And TRIC told us that the use of a threshold for red cell transfusions as low as 7 grams per deciliter, because it was in American units, so 70 grams per liter here, was at least as effective and possibly superior to a liberal transfusion strategy in critically ill patients with normovolemia, with a trend towards decreased 30-day mortality among the patients who were treated according to the restrictive transfusion strategy. And that was in 1999. And so, the question would be is, why do we then need to do this work? Why is this necessary? Well, TRIC and other studies like it, and there have been quite a few, have informed innumerable guidelines. There are so many out there. How do you know what to do? How do you know what to follow? Choosing wisely tells you one thing. There's a national advisory committee on blood products. There's our local stuff within Alberta Precision Labs. What do you follow? And where is that? Where is that guidance? And then Alberta data still shows that despite TRIC, we're still providing guideline incongruent prescriptions. So hence the need for this work, and part of the reason why we got funded. So before we get into what we're bringing to you, what I thought we would do is just introduce what it is and what it isn't. As I know everybody's busy and all emerging from the effects of COVID, everyone's kind of worn down and, often not looking for extra stuff to take on. So the Don't Misuse My Blood project is not extra forms. It's not self-auditing. There's no case report forms there. There's no extra charting. We resisted the temptation within the implementation intervention to impute pop-ups within Connect Care. So there's no pop-ups that come up as a result of this. You don't have to click through anything. I'll show you how you get to our clinical decision support tools. So it should really bring no additional costs or resources, no change in roles or workflow. It's a provincial QI initiative. So as I showed you, the target population is large and it is across the province. We're seeking to optimize transfusion prescriptions. It's evidence-based, as hopefully I'll show you. It's stakeholder informed and it's multimodal. So that's what the project is, and that's what it is. This is our team. We have a large team that's been doing all the heavy lifting to move this forward. In the interest of time, I won't go through everybody's name, but you can see them there and they're on the slide for reference. We had to decouple the work initially as it was pitched in the grant. We were going to do it all at once. And of course, once you get going, then you realize, that wasn't possible. So the blood transfusions work was far more ripe for implementation. There are a ton of guidelines there. We just needed to put them into an implementable package. Whereas the blood tests work, there's really minimal existing guidelines. There's lots of stuff out there that tells you should reduce unnecessary blood tests. What does that mean? How do you operationalize that? When do you seek to do that, and what are those tests? So we're doing some work there to try to, get to a point that we have an implementable product. So that's separate. Whereas the transfusions work just needed a distillation of existing guidelines, which the team did, went through hundreds of recommendations, lots of details, coupled with what transfusion medicine in Alberta had already created, which just needed a little more nuance given our patient population. We built consensus with provincial stakeholders, and here we are, launching the intervention through a multimodal approach, as outlined there. This just shows a timeline. Suffice it to say, it's a large project. We're doing 40 implementation sites times 2, in that we have to do this both for blood transfusions and blood tests. And of course, it would have been nice to do this, in a way that somehow linked the two, but the blood test work just wasn't ready for that, and we needed to get going. So we're employing a step wedge design. We're bringing 4 sites per month times 10 months. This is just a snapshot of the guidelines that we created. So the guidelines that we created, as I said, are complementary and supplementary to what exists already through Alberta Precision Labs, and they were super helpful in helping us, create something that was congruent with what they had already stated, but also was in response to the nuance within our patient population. The final product is a 1-pager on each product, and I'll go through them so that you can see those. They're accessed via QR codes on computers and posters, the CCSTN website, hard copies on the units, and we've actually got little pocket cards you can put in your lanyard where you can then just snap the QR code and get to this. So we'll go through the red cells recommendation. And the first important part with both of these, with all these really, is that we've split them up into bleeding, not bleeding. One of the things we heard as we were doing this work was that the approach for this is very different in a bleeding versus a not bleeding patient, which as a clinician, I totally get. So we had to come up with both a data and a clinical definition for what would define, what's significant bleeding? Obviously, we can all recognize what's massive hemorrhage and, what requires a massive hemorrhage protocol. And then there's the sort of nuisance bleeding, maybe a little drip epistaxis. That's not really, creating a big hemodynamic or hematologic problem. So clinically significant bleeding was just that. It was some blood loss plus a hematologic or hemodynamic perturbance associated with that blood loss. Or you're doing something for it. You're ordering a test to stop the bleeding. That's clinically significant bleeding. So we've got the major hemorrhage, clinically significant bleeding, and non-clinically significant bleeding. And then on the other side, we have all the non-bleeding indications where you might want to transfuse red cells. So with regard to the bleeding recommendations, I went through the definition of clinically significant bleeding and how that differs from the other two. And really for major hemorrhage, we want you to use AHS's massive hemorrhage protocol. It's been there. It's actually revised as of late, and it's going to be revised. Their approach to it is revised, wherein you're no longer going to get a bag of platelets in the pack. You're gonna have to call for platelets if you want platelets. There's actually more fibrinogen, and they're seeking to provide a more laboratory-based targeted approach to transfusion as opposed to a blind fixed ratio approach. So that's the bleeding slide. With regard to the non-bleeding recommendations, you can see there's a number of things that were nuanced that weren't really within the Alberta Precision Labs guidelines that we thought were appropriate in that our data tells us this is where some of the ongoing use exists. And we'll spend some time going through the ischemic cardiovascular disease one, as I think that's really important for this group. But suffice it to say, you can see, the little snapshots of all the science there that underpins some of the recommendations. So for the general adult patient, in a critical care unit, you've got TRIC that informs that transfusion threshold of 70. There's, no different in septic shock when they examined it in septic shock. We've got some nuanced stuff in the context of ischemic cardiovascular disease that we'll go through. Cardiac surgery for a hemoglobin less than 75, as per the paper there. And then if you have acute neurologic injury, really the jury's out on that. There's active trials undergoing. There's, cultural practices associated with when you ought to transfuse somebody in the context of acute neurological injury, but it was really hard to define a number. So we just refer people to trials if they have those such patients. So we'll go through this reality trial, which I'm sure is familiar to a lot of the people in the room. And maybe some of this is just going to be redundant, but I thought it was important given the audience, to go through, what reality has at least told us to this point. So the reality trial published just a couple of years ago, randomized nearly 700 patients with an acute MI and a hemoglobin between 70 and 100. Either restrictive transfusion, which they defined at a hemoglobin level of 80, or a liberal transfusion, which they defined at a hemoglobin level of 100. It was a non-inferiority trial, and the primary outcome was a composite of death, ischemic stroke, acute MI, and emergency revascularization. When you look at their patients, it was a mixture of non-STEMI and STEMI that was pretty balanced. And their KILLIP classification was as well pretty balanced, with up to 15% in the restrictive group that were KILLIP class 3, suggestive of a fairly sick patient population. And so from this trial, what these authors showed was that a restrictive approach was non-inferior to a liberal approach. When you look at the composite primary outcome, it was 11% in the restrictive group and 14% in the liberal group. And then each of the subsequent components of that primary outcome did not differ between the two groups. Of course, when you look at the numbers of red cells transfused, there's a big difference, as you might expect. So, almost 100% of the patients in the liberal group got at least 1 unit of red cells, for a difference that was nearly double the total numbers of red cells in the liberal versus restrictive group. And then if you just look at the survival graph on the right, you can see that, the rate of major cardiovascular events, at 30 days was not statistically significant, but it suggests it was lower in the restrictive group. So what's going on here? This ought to be that red cells should benefit this patient population, right? They've got a myocardium that's struggling. If they've got a low hemoglobin, you ought to improve oxygen delivery by giving hemoglobin. You ought to improve myocardial performance and therefore reduce the ischemic symptoms and their sequelae, which should make this patient population do less well if you hold back on hemoglobin transfusion. But there's another side to this. There's another part of the biology that I think is evolving and being understood, and the trials are starting to help us understand this, which is that, with transfusion of a colloidal product like red cells could come fluid overload, could come increased viscosity, could come immunosuppression and inflammation. But then moreover, and really interesting, could actually come platelet activation, from the nature of the age of the red cells and some of the nutrients that might be deplete at that point in time, and therefore microvascular vasoconstriction and a worse outcome. So the trials are seeking to answer this question. It's not by default beneficial, and that's why they've got equipoise and they're doing the trials. And so fast forward to a year out. So this is the reality outcomes published in 2022, a year out, not 30 days. So this is a year of their composite outcome. And you can see that, there is a bit of a crossing there in terms of the liberal versus the restrictive group, such that at a year, there is then no statistically significant difference. They have similar rates of adverse cardiovascular events. So then what does one do? Well, you do a bigger trial. So, now we've got the MINT trial that I think the Foothills, at least the Foothills site was a participant of, is my understanding from speaking with Greg Schnell, where they're looking to get, and I think they've completed enrollment at 3,500 patients, a similar approach to liberal versus restrictive transfusion. Except interestingly in this group, when you actually read the details of the text, if you get into the restrictive group, you can get a unit of red cells at a hemoglobin less than 80, but you don't have to. It was possible that you could hold back in that context. If they were having anginal symptoms or symptoms you think were benefit from a hemoglobin transfusion, obviously it could be provided, but otherwise it was encouraged strongly if they were less than 70. And then of course, in the liberal group, you basically got a unit of red cells as soon as you were randomized, because you were randomized at a hemoglobin less than 100. And so they have a composite outcome similarly of all-cause mortality and 30-day recurrent MI. And I looked this up, but I didn't see anything there suggestive of any early results. I think they've just finished enrollment. So, stay tuned for that one. So we'll move on now to platelets, and we'll kind of buzz through some of this just in the interest of time, because there's a lot there. Again, broken up into bleeding and not bleeding. What I really wanted to call your attention to was within the bleeding patient population, for those that have platelet dysfunction, which would of course be many of the patients in the CCUs owing to pharmacology, there really is no transfusion threshold there at which one could give platelets. The platelet, if the patient has clinically significant bleeding, and they have platelet dysfunction, they can be given platelets at any count. You just have to call and speak to the transfusion medicine specialist. Similarly, if they have undergoing a procedure. So this is a really interesting one. There's actually a recent trial in the critical care literature on procedures and central line insertions with thrombocytopenia. So if they have a central line, or if they have a high risk procedure and they have platelet dysfunction, then obviously same thing. There's no number against which to transfuse. The platelet transfusion ought to be given. You just have to talk to transfusion medicine. But when it comes to low risk bleeding procedures, which the interventional radiology literature would define as ART-line CVCs, a lot of the stuff that we do, quite commonly, in our critical care units, there is an emerging literature on transfusion of platelets. And so there was this trial just published this year in the New England, that randomized, it was a hematologic and critically ill population. So it was mixed. Some of them were in the ICU, some of them on hematology ward. And they all had mostly production-related thrombocytopenia, not consumption, as you imagine. That'd be hard to randomize those patients. And they were getting central line insertions. So they randomized them in the context of entry platelet counts that were between 10 and 50, either getting platelets or not getting platelets. And what they showed was that there was no overall major difference in the primary analysis, but the difference that did exist in terms of bleeding was within the patients that got subclavian vein punctures, which, full disclosure, I love the subclavian vein for central line insertion, and I would not have put subclavian line in these patients with their platelet counts being so low. But in any event, they did, and of course there was more bleeding in the group that didn't get platelets. And then moreover, the hematology patients seemed to bleed more than the critical care patients. So I think, further data to come on this. This was really the first meaningful trial that was done examining platelet transfusions in patients with thrombocytopenia getting central line insertions. But it's largely congruent, with what our group had put forward, which was great because this was published in the summer and we'd already created our decision support tool. So I was glad it didn't sway us the other way. With regard to plasma, again, I won't go through everything because there's just a lot there. I think what's really important from the perspective of plasma is that this slide right here. So this slide I got from Dr. Naherniak, who's one of the transfusion medicine physicians in Edmonton. It kind of runs transfusion medicine in Alberta. And so, we have to remember that with regard to the INR, we're not really in a zone of anticoagulation until our clotting factors have dropped to around 30% of normal. And that's really reflective of an INR of 1.7 or higher. So if your INR is less than 1.7, let's say it's 1.6, with a bag of plasma having an INR of 1.4 to 1.6, you're not really going to make a dent in that INR by giving them plasma. In fact, you're probably just going to contribute to risks of volume overload. And at that point, I'd argue it's not really medical bleeding. It's probably bleeding from something else. So I think this is really important. This is something that I've learned as I've done this work is that, transfusing plasma for an INR less than 1.7 is really not offering the patient any benefit and should be avoided. With regard to fibrinogen, same thing, because I want to get to your data. I won't spend too much time on it, but the teaching point there is that I think we actually underdose fibrinogen most of the time. I had historically been giving 1 gram, maybe 2 sometimes, whereas the new massive hemorrhage protocol is going to bring you 2 to 4 grams, because I think that's what most people end up needing. And there are special circumstances that dictate certain fibrinogen levels to transfuse to, but 1.5 is a really good number to keep in your head. And then PCC, in the interest of time, we'll flip past PCC because it's not really driving a lot of the change. Because of course you want to show you your data to show you, where the relevance to all of this is. So this is Alberta ICU, CVICUs, all the critical care units, all lumped into one. This data takes into account the nuanced circumstances that the clinical decision support tools have outlined, i.e. are you bleeding or not? Are you having a procedure or not? All those things you might question when looking at red cell transfusions. At the beginning of the talk, I mentioned that up to 60% of transfusions are potentially unnecessary. Well, a further refined estimate based on a really detailed algorithm within Alberta data suggests that's actually 50%. So it's still pretty high. It's lower than 60% when you add in all those factors, but it's still pretty high. The total numbers of transfusions put on the slide there obviously is large. It's probably an underestimate because this is all Connect Care data. So this is Connect Care sites over the time. And this has been rolling out in a staged manner. So there's some sites here that won't have contributed to this. So the absolute number of transfusions is an underrepresentation, but the proportion is accurate. With regard to the CCUs, this isn't a prominent feature of your practice. This, is a feature, but it's not a prominent feature. When you look at the red cell transfusions within the CCUs in the Calgary zone, again, Connect Care sites, from May to June 2023. So there's going to be a big gap there, right? Which is that, the Foothills that just launched in November is not going to have contributed as much to this as it would have with a year's worth of data. And the reason we had to focus on Connect Care was we had to get this project ready to go in Connect Care as it was going to all the sites. So we couldn't go and do it in MetaVision and in Connect Care. It had to just be in one source. So that's why it's excluded. Again, the numbers are around 50% of transfusions are potentially unnecessary, largely driven not so much by the ischemic cardiovascular disease patients, but the sort of grab bag of a bunch of patients that have other types of admission diagnoses, that are getting red cells for hemoglobins that are greater than 70. With regard to plasma, the proportion of plasma across the province that's potentially unnecessary is around 40%. And I won't go through all of this in detail because I want to give you time to ask questions. And I know this room is going to be taken over by others, 10 to 9. With regard to platelets, which are also around 40%. Fibrinogen's around 60%. And then this just shows the Calgary zone CCUs in contrast to the Alberta CCUs. Again, it's a low volume practice for some of these products. Red cells is your higher volume practice. You can see when it comes to red cell transfusions, in comparison to the Alberta CCUs. So that would mostly be composed of, Edmonton being the other high volumes CCUs. There's a little bit more red cell transfusion, maybe a little bit more plasma, a little bit more platelets. So, an opportunity, I think, moving forward. How do we get this into your practice? Well, we're trying to be as seamless as we can. We do have the pocket codes here. I have some with me for anybody who's interested. They just fit in your lanyard, and that QR code will get you to our decision support tools. As I said, we resisted the temptation to put a pop-up in Connect Care. Like, as a Connect Care user myself, I am totally fatigued by all those pop-ups. I think they've lost their effect. There's so many of them. So, rather than putting another one in there, we sought to do this a little bit differently. We are right now working on getting this within the transfusion medicine order set, so that big white space there that could be occupied by something, would have our QR code in it. So there's work in place to try to do that. And as you can imagine, that just takes a little bit of time to infiltrate Connect Care. When it comes to ordering blood products in Connect Care, it's important, I think, to spend a little bit of time just reviewing this, as was the hope of some of my transfusion medicine colleagues who don't have as big access to a clinical population. So when it comes to massive hemorrhage, it's really important, if you want a massive hemorrhage box, if you want the products of that box, that you order the massive hemorrhage protocol order in Connect Care. And there's 2 reasons for that. One is it makes the documentation available for the nurses. 2 is it actually gets you the labs ordered with an MHP tag, so that if the patient's bleeding, the lab knows to run that fast and get you the order fast, because they're moving towards a titrated approach to blood product transfusions, not a blind ratio approach, as was the case for probably the last decade. So you need the labs. So really important that you use that order, and I've used it myself. It's quite good, and it's quite fast. All it does is requires a phone call to transfusion medicine just to say, hey, we need the box. And moving forward with the new MHP protocol, which we did not design, that was part of Alberta Precision Labs, you won't get platelets. So you'll have to call for platelets and speak to the doc to actually get platelets released. Then there's these other two. So this emergent orders one, what is that? And how does that differ from ordering it stat, in the regular transfusion order set? Well, think of the emergent orders one as you want uncross-matched blood. You've got big time bleeding and you don't have a cross-match yet, and you want uncross-matched blood. That's when you should use the emergent orders, because it only creates an order for the nurses to sign off. And then you still have to call transfusion medicine so they can get the product. But it gets you uncross-matched blood, generally speaking. And then there's the routine order, but you can still get stat blood through the routine order. You can still get red cells that way. If they have a cross match, that's probably the way to go. And then that's a little bit more straightforward. Okay, so that's pretty much the end of what I had to say. When it comes to next steps, I've got a couple of implementation leads working with me who are going to be providing education to staff. There's an audit and feedback reports, that'll show up in a few months. And the timing there will depend on usage. Some of the usage is lower volume, so we need to wait for enough time to actually accumulate data to meaningfully provide a report. Whereas some of the units, for example, some of the ICUs are a lot higher volume, so they're probably going to get data a little bit more frequently. But that's reflects the pragmatism of doing this kind of work. The goal, of course, is not to eliminate, the potentially unnecessary products as captured in the data. To do that, I'd have to have perfect data. We don't have perfect data. It's really good, but it's not perfect. There's going to be flaws in it. But I think if we can make a big dent in a 30% relative reduction, then that would be quite useful. And with that, I will take questions.
Thanks very much, Dan. That was fantastic. We will throw it open to questions, both online and in the room. I'll start with a question, and you kind of avoided this, I think, in the talk, for maybe good reasons. What do you think is driving inappropriate transfusion? Is it a lack of education in physicians, or is it other causes? What are your thoughts on that?
Yeah, good question. I mean, I think at the end of the day, everybody wants to do the right thing and what they perceive to be the right thing. I don't think it's malicious use of red cells. I think some of it, and I didn't present this data, but we have it. Some of it relates to the observation of trends and the trigger at which to transfuse. So 70 is the cutoff. So what we've seen a lot of is between 70 to 75 is where people are getting red cells between 70 to 75, which is you've got this probably slow trickle of hemoglobin, that's going down over a period of days. Today it's 73. Your guess is that tomorrow it's probably going to be in the 60s and you're going to need to transfuse. I'll just do it today, right? I'll just transfuse today. Whereas a lot of the time, and that probably was my practice, before I started doing this as well. A lot of the time, what I've found is if you wait, it might not actually go down to the point that you need transfusion, or it might take a few days, and then there's just, less exposure to the blood product. So there's a lot of that's happening as well. I think some of it relates to potentially education, although I highlighted, Trick is now almost 30 years old. And then some of it relates to the nuance. Our data is not perfect. We've done a pretty good job, I think, of algorithmically going through and trying to pull out the patients who should get red cells and separating them. So we're left with a population that looks like they ought not to have gotten red cells. But again, it's a high level look at, large amounts of data. Whereas if you go through line by line, you might pull out a few patients in there where you could say, okay, I get that. I could see why they got red cells. So, although the number presented is around 50%, it exists within a range, that could be, it could be 30%, it could be 60%, it's not going to be, perfectly precise. So I think that would be great if we had that, and then we could see exactly what it was. But, nonetheless, there is that opportunity. I think it's driven by a lot of that lower, close to transfusion threshold group that I think a lot of times if you wait, they probably don't need anything.
Check the chat if people want to put in questions. Oh, Greg. In the chat there.
Hey, Andrew, Dan.
Oh, there we go.
Thanks, Dan. That was very informative and I think very helpful to the group. I certainly look forward to the laboratory advice we give to people. I see this all the time in our world where, people have CBCs ordered for weeks on end after they get admitted. But just 3 comments. that might help guide some discussion. You know, MINT is completed, as you pointed out. It's been done now for about 3 to 6 months, so I expect we probably have data in the next year. My impression is it's primarily a trial of type 2 or demand ischemia in older people rather than kind of the acute MI population like reality. So it may help inform us and guide clinicians pertaining to the group of patients where you saw the greatest use of PAC cells, which is kind of the patients on the ward where I think their hemoglobins drift down and people get worried. So that is to look out for, and again, might help our group sort of guide management on the ward patient. I think one of the areas that might be interesting for our group to look at, and I see Claire's on the line here, so Claire, I might task this to you to talk to your colleagues in the cath lab. Is there some disparity about transfusion threshold or hemoglobin level when patients are coming for angiography? You know, we don't lose a lot of blood in the cath lab with radial approach, but people are worried they're going to get a bolus of heparin and things like that. So there's been some disparity there. And I think it would be helpful for our group to provide some guidance as to what kind of threshold is needed for coronary angiography. And last but not least, it's sort of a pet peeve of mine, Dan, but you know, I think the CCU in particular is, I call it the GIGU stress lab, right? I mean, if you have a potential to bleed from an occult malignancy, we're going to find it because we give fairly potent anticoagulant drugs, which is good in some circumstances. You know, we've discovered no end of GI cancers and urological cancers, but you know, there certainly are a fairly significant number of patients where we could probably tailor our therapies a little bit better. So I've been trying to champion the avoidance of routine dual antiplatelet therapy as one area where we can try to minimize the bleeding risk. And secondly, I think, you know, we've got pretty good clinical trial evidence that fondaparinux is a better agent in terms of bleeding risk in patients with acute coronary syndromes compared to low molecular weight heparins, particularly in older people. So for people on the line and for our trainees, you know, consider fondaparinux rather than low molecular weight heparin. But thanks again, Dan. This is excellent work and a lot of really fantastic work by you and your group and a lot of hours spent analyzing really helpful data. And I think how you've formulated it, particularly when it comes to the red cells, is excellent.
Thanks, Greg.
McAdams?
Thanks. What you said, just to clarify one thing. So is that sort of when you approach to the 70s, that where you find a lot of those inappropriate people happening? Things trickling down. And if so, I'm just wondering, that might be a really hard one to, you know, change behavior with knowledge translation or trial data. It's hard to design a trial to specifically address that.
Yeah, it's funny, like the when I started doing this work, I had assumed, you know, that at a hemoglobin of 70, like you got to or hemoglobin 69, you got to transfuse them right now, you know, and in some patients that might be the case, you know, in a small number, but most of them are still okay, you know, and they're not gonna, you know, infarct or have a stroke all of a sudden, you know, right now. So if it happens to be that you come in the morning and you see that, you know, no problem, we'll just give them a unit of red cells. I didn't think of it that way before, you know, until I was, you know, working with some of the people who are interested in this. But you're right, you know, I think it's hard. I think the one thing to remember is TRIC did enroll people from 70 to 100. And, you know, that was the case in most of the other trials, keep the ischemic cardiovascular disease patients out of it, you know, who were enrolled a little bit higher. But, you know, nonetheless, yeah, I think that's the group. That's one of the groups to target. It's not all of them. What's interesting, and I don't have it here, I wish I had it to show you, but there was actually a really considerable portion. Now I'll speak to the ICU world itself. A really considerable portion that were actually transfused at a hemoglobin above 80, which was like, well, you know, why is that, right? We've pulled out the patients that had, you know, bleeding to the best we can, procedures to the best we can, ischemic cardiovascular disease the best we can. Those are all separate, but yet there was still a chunk, a good chunk, that we're getting a red cell transfusion at a hemoglobin greater than 80. So, you know, why is that? So even if within that group, you know, we could intervene, and then some even higher, you know, at 90 and 100. So even within that group, if we can intervene, I think we can, you know, work towards our 30% relative difference.
Any other questions online or in the room? Oh, there we go.
It's a question about high dose diuretics in between each unit transfused for acute decompensated heart failure. I would say that, you know, this, that wasn't a focus of this work, and I would, lean on the experts to tell you what to do there, which wouldn't be my domain. So I might do that, I might not, depends on the patient, yeah.
Great. Well, as we are limited in this room, I think we will close that, and thank you very much, Dr. Niven.
Thanks, yeah. Yeah, a bunch of angry students coming in here.